So good evening once again, colleagues. Welcome to this weekend's tutorial. And this weekend we'll be looking at a very important topic in the ICU. And I'm sure many of us are familiar with that. Acute Respiratory Distress Syndrome, ARDS. That's what we'll be looking at this evening. All right, so our learning outcomes is outlined above. At the end of the lecture, we should be able to understand the clinical definition and the diagnostic criteria for ARDS. We should be able to recognize the common risk factors and the underlying causes. We should be able to explain the pathophysiological mechanisms leading to ARDS and how this impacts on gas exchange, because that is the most important thing here. Be able to differentiate between mild, moderate, and severe ARDS based on the Berlin criteria. And we should be able to identify key clinical features and presentations of patients with ARDS and understand the role of imaging, blood gases, and other diagnostic tools in ARDS. And of course, we should be able to discuss evidence-based treatment approaches, which includes non-protective ventilation, propositioning, and other adjuvant therapies. So those will be our learning outcomes today. This will be our outline. We'll follow this outline, right? And the first thing we're going to do, I want us to look at this clinical scenario, and we'll try to answer the questions at the end of it. I hope you can hear me, everyone.
Yes, Prof. Yes, sir.
Okay, and the slide is moving this time around.
Yes, sir.
Yes, sir.
Okay, so let's look at this clinical scenario. A 55-year-old male patient with a history of hypertension and COPD has been admitted to your ICU with severe sepsis secondary to community-acquired pneumonia. He was initially treated in the emergency department with IV fluid, broad-spectrum antibiotics, and non-invasive ventilation for worsening respiratory distress. Despite this, his condition has rapidly deteriorated with increasing oxygen requirements and respiratory fatigue. Initial investigations revealed ABG pH of 7.25, PaCO2 of 60 millimeters of mercury, PaO2 of 55 millimeters of mercury on FiO2 of 100. Chest X-ray revealed bilateral diffuse opacities, which is consistent with pulmonary edema and consolidation. Lactate is high, 4 millimole per liter. And on the complete blood picture, we have WBC 16,000 per microliter, hemoglobin is 11, platelet is 150, and all that. So what is your working diagnosis from this history and examination, and how will you manage this patient? All right, let's have one or two persons make a go at it. If you have this patient before you, what will be your diagnosis, and how will you go about managing this patient briefly? Anyone, you can mute yourself and talk. Anyone? Any attempt?
Good evening, sir.
Yeah, increase your volume. We can hear you, Dr. Wangu.
Good evening, sir. From the ABG results, the patient has, sir, please, can you hear me?
Yeah, we can hear you now.
From the ABG result, the patient has respiratory acidosis with severe ARDS.
Okay.
From my if the patient is intubated, I would like to increase the respiratory rates so I can blow out the CO2 that is accumulated. I'll hyperventilate the patient. Then for the ARDS, I would like to reduce the tidal volume to about 6 mL per kg for the patient.
Okay. Good attempt. Good attempt. So ARDS secondary to what? What precipitated this ARDS?
The patient has sepsis, severe sepsis.
Yes.
Secondary to community-acquired pneumonia.
Okay. So what you've just talked about that is just the only ventilatory aspect of the management. Any other thing you're going to do?
Oh, I will treat the underlying cause for the patient.
Okay. Good attempt. Any other person wants to add to anything missing in this discussion? Anybody? Quickly, quickly. Is Chris Lowe on this call?
Yes, Prof. How are you?
Attempt this case.
Okay. So I would do lung protective ventilation. As mentioned, it's 4 to 8 moles per kg of predicted body weight for the tidal volumes. Then permissive hypercapnia, limiting our pH to above 7.2. And then we'd also increase the PEEP. And then so we start with a high FiO2 of 100 and then titrate down. And then we titrate up our PEEP according to the ARDS net guidelines. And if the patient requires muscle relaxation or deepening of sedation, we may have to opt for that to take over control of ventilation. And corticosteroids is controversial.
Okay. What do you think is the primary problem here? What is the primary principal problem in this patient? Anybody? Chris, we can't hear you. You are breaking. We can't hear Chris.
Antibiotics.
We
PD.
lost
Sorry,
you. We couldn't
I'm
hear
on
you,
call.
Chris.
And can you hear me now? Can you
Yeah,
hear me?
okay, it's better now. We lost you. We couldn't hear you. You were breaking.
Yeah, so sorry. The underlying problem, I think it's the sepsis. So we'll have to treat with antibiotics, but there's also a background history of COPD.
Okay.
So we may also need to take that into consideration with increasing IE ratio to allow for the blowing out of PCO2.
Yeah, here I'm hearing blowout CO2, agree. But apart from the fact that the underlying problem is sepsis, what is actually the problem with this patient? Look at the ABG. Look at the ARDS. Ungomsi, you want to say something?
The patient have pulmonary edema, so I think I'll give the patient furosemide and reduce the IV fluid.
Okay. There's something missing that is very glaringly obvious that is part of the definition of ARDS from the ABG. If that is not taken care of, you are not managing this patient. What is the problem, Fatima Dusote?
There is hypoxemia because despite
severe hypoxemia,
there is still not we're still not achieving adequate saturation in this patient. So there is hypoxemia.
There's severe hypoxemia. All right, and if you put into account the definition of ARDS, as we're going to see, ARDS is actually characterized by refractory hypoxemia. Okay, if you look at the history, despite this condition, all right, the patient has deteriorated with increasing oxygen requirement and respiratory fatigue. All right, and it's not even the saturation. Look at the PaO2. The PaO2 is 55 at FR2 of 100. What is the PF ratio here? Somebody quickly calculate it. I hope we know what we mean by PF ratio. What is PF ratio here? Fatima?
55.
Yes, go ahead. The person talking, sorry, I didn't get your name.
It's Dr. Nkomo. PFA ratio is 55. That's
55 over
55 divided
100.
by
What is that?
over 1. FI2 over 100. The FI2 of 100 is the FI2 of 1. So that's 55 divided by 1. So that's 55. So this is severe ARDS.
Severe
Less than 100.
ARDS. Severe ARDS. All right. And what you're going to do here is that you want to do everything to optimize oxygenation. All right. That is what you're going to be looking at. All right. FiO2 of 100, PaO2 of 55. Let me ask you, what other index of oxygenation may you consider here? You have the PaO2, you have the FiO2. What other index of hypoxemia or oxygenation are you going to consider here? Anybody?
There's oxygenation index.
What other index? Yes?
There's oxygenation index. Where
Beautiful oxygenation index, yes. What is oxygenation index?
So we use PaO2 and the mean airway pressure divided by the FiO2. So if it's less than 25 to 40 or more than 40. If it's less than 20, yeah.
It tells there's one more. There's one more that I want us to talk about. There's one more that you're going to use in terms of oxygenation, and to also, it will help you to decide the type of hypoxemia you have.
AA gradient.
AA gradient. Thank you, Chris. What is AA gradient?
So AA gradient is the difference between the arterial as well as alveolar oxygenation.
So it tells the other way difference between alveolar oxygen concentration and arterial oxygen concentration.
Yeah.
So you can have normal AA gradient, you can have increased AA gradient or severely increased AA gradient. All right. I hope we are following. So let's go on. Good attempt, everyone. And don't forget, in all of this, you also want to do supportive care. Okay, so let's go on. Good discussion. And so let's look at ARDS. It's defined as an acute, diffuse, inflammatory, life-threatening lung infection that's characterized by bilateral lung infiltrates and severe progressive refractory hypoxemia in the absence of any evidence of cardiogenic pulmonary edema. One of our colleagues mentioned pulmonary edema. I wanted to ask, you need to differentiate between cardiogenic and non-cardiogenic pulmonary edema. So the pulmonary edema from ARDS is of a non-cardiogenic origin. All right. Most of the times, ARDS develops as a result of an inciting event. In our clinical scenario, we looked at the inciting event was severe sepsis, secondary to community-acquired pneumonia. All right, so inciting events, put it at ARDS. So it could be due to aspiration pneumonitis, ear embolism, amniotic fluid embolism, respiratory infections, like in this case, community-acquired pneumonia, drowning or near drowning, drugs such as blood transfusion from, what's it called, a transfusion associated lung injury or TRALI. It could be due to sepsis, smoke inhalation, or the stress of trauma. So these are the inciting events that can precipitate ARDS in your patient. And it's important also to look at those inciting events and the underlying cause so that you can have a comprehensive management of your patient. All right, so there's been a lot of definitions over the years, but in 2012, the Berlin definition was adopted, which differs from the previous American European consensus. Here, the Berlin definition excluded the term acute lung injury, all right, included the need to have the pulmonary capillary web pressure, all right, which should be less than 18 centimeters of water in case of ARDS. In cardiogenic pulmonary edema, your PCWP should be more than 18 centimeters of water. The Berlin definition also included the requirement for PEEP. All right, so when the patient requires a PEEP greater than 5 in order to optimize or maximize oxygenation, it falls into the definition of ARDS. Recently, some years ago, maybe 2016, 2017, the Kigali modification was actually, brought into the limelight, recently published by the American Thoracic Society. So we know as the Kigali modification, and here it replaces your PaO2 with your SpO2. All right, so SpO2 over FiO2 ratio of less than 315 is considered indicative of ARDS. All right, also the Kigali modification emphasized the use of lung ultrasound, not just chest X-ray, included the use of lung ultrasound in the diagnosis of ARDS. The lung ultrasound is said to be particularly emphasized because it's more accessible and feasible in resource-limited settings compared to mobile X-ray or CT. In many of our centers, we may not have mobile X-ray, and to move an unstable patient to the CT or the radiology suite may be cumbersome. So lung ultrasound was particularly emphasized, all right, to include the definition of ARDS in the Kigali modification. ARDS is quite common among ICU patients with a mortality range between 26 to 58%. And the major cause of death in ARDS is actually non-pulmonary multiple organ dysfunction syndrome, often associated with sepsis. Our patient here had sepsis secondary to community-acquired pneumonia. Okay, and it's also been said here that approximately, 30% of cases of ARDS are due to pneumonia, respiratory infection. So the pathophysiology of ARDS progresses through different phases. I want you to know that the first thing is inflammation, all right? Whatever the cause, maybe from sepsis, maybe from any other thing. So it progresses through 3 different phases: the exudative phase, the proliferative phase, and the fibrotic phase. All right, in the first 3 to 7 days after an inciting event, all right, the exudative phase sets in, which is characterized by alveolar capillary damage. All right, this leads to development of alveolar edema, like we see in this patient, and proteinosis because of inflammation. The alveolar edema, all right, fluid in the lung replaces the air in the lung and reduces gas exchange. And this is what leads to the refractory hypoxemia that is seen in ARDS. After about 14 days of the inciting event, if not treated, you have the proliferative phase. all right, which is characterized by increased number of type 2 pneumocytes. Clearing of alveolar edema begins to occur, and here you have improved lung function and healing. This takes place over a period of 2 to 3 weeks. The fibrotic phase signals the end of the acute disease process, and here the patient develops progressive interstitial and alveolar fibrosis. It is important to note that the pattern of injury that you see in ARDS is not uniform, as the bases of the lungs are more affected than the apices. All right, so this intrapulmonary differential pathology results in variant response to oxygenation strategies because you have the bases of the lungs more affected than the apices. All right, you realize that with increased PEEP, and in as much as you want to improve oxygenation by incremental increase in PEEP, you also run the risk of volume trauma and arterial trauma, especially of the unaffected alveoli. So there's a differential pattern of injury that is seen in ARDS. All right, so this is a table to just give you an example, a picture of what happens during the pathophysiological progress of ARDS. The first 1 to 7 days, the sedative phase, which is characterized by acute lung injury from inflammation, cytokine release, and all that, with pulmonary edema, diffuse alveolar damage. All right, and this is what causes the aposemia that you see due to VQ mismatching. And note that, like what we discussed, your AA gradient is important because it helps you to differentiate between, hypoxia that is due to, what's it called, reduced FiO2, or hypoxia due to shunting. All right, in ARDS, there's more of shunting taking place because of VQ mismatch. Proliferative phase takes about 7 to 14 days, and this is when you begin to see healing, all right, lung repair, resorption of pulmonary edema, and there's a gradual decrease in inflammation. After 14 days, some of these patients develop lung fibrosis that can make them become ventilator dependent because there's persistent inflammation, chronic scarring, and this is where steroids play a role. As we go on, we'll find out that early steroid administration in ARDS has not been associated with better outcome. But when you start steroids in the fibrotic phase, it's been seen to help improve outcome. Why? Because steroids help to prevent the scarring and collagen depositions in the lung alveoli. So this is why steroids is important. Good exam question: when do you want to initiate steroid therapy in patients with ARDS? It's usually during the fibrotic phase, about between after 14 days of the onset. All right, so this is another table to show you. You have the risk factor. You remember what we mentioned about the risk factors: the aspiration pneumonitis, amniotic embolism, respiratory infections, near drowning, drugs like blood transfusion, sepsis. So this is the risk factor. Now let's take our clinical scenario. The risk factor here was sepsis due to community-acquired pneumonia, and this will elicit inflammatory response. This inflammatory response will now lead to the pathophysiological phase of exudation, proliferative and fibrotic phase. And all of this will lead to alveolar flooding because of the damage of alveolo-capillary membrane. So you have pulmonary edema here. And all of this will lead to surfactant abnormalities, closure of the small airway with shunting, and this will lead to hypoxia. Now, this hypoxia is refractory to conventional oxygen therapy requiring invasive mechanical ventilation. And don't forget, mechanical ventilation also has its own problems, the complications. So this slide gives you a complete picture of ARDS as it develops in your patients. All right, so the American European Consensus Conference they put some criteria to differentiate between acute lung injury and ARDS. Both of them they are of acute onset within 3 to 7 days of inciting event. The PF ratio for ALI, acute lung injury, is less than 300, while that of ARDS is less than 200. All right, they both have bilateral infiltrates, which is consistent with pulmonary edema, all right, but no clinical evidence of cardiac involvement in this patient, especially when you measure your pulmonary capillary wedge pressure. All right, it's important that you distinguish between cardiogenic and non-cardiogenic pulmonary edema. Remember that ARDS is of a non-cardiogenic edema. Is somebody saying something? Daniel Young. Okay, I think it's an interruption. All right. So it's important for us to differentiate between cardiogenic and non-cardiogenic pulmonary edema. The non-cardiogenic pulmonary edema is ARDS, all right, that fitted into the definition of ARDS. But look at it, if you look at it very carefully, you will see that there are two ways to differentiate or distinguish between ARDS and cardiogenic pulmonary edema. Like we mentioned, the first one is the use of your pulmonary capillary wedge pressure. All right, so PCWP less than 18 millimeters of mercury is evidence of ARDS, while greater than 18 is evidence of cardiogenic pulmonary edema. But the drawback here is that you require your pulmonary artery catheter, which is an invasive procedure, all right, for you to be able to measure your wedge pressure. All right, and a lot of times it has also shown that it's not really a good guide into pulmonary edema. The second one you can use is your bronchoalveolar lavage. Often not readily used in most ICUs, but it can actually differentiate between cardiogenic and non-cardiogenic pulmonary edema. All right, if the pulmonary edema is of a non-cardiogenic origin due to inflammation and inflammatory cells, neutrophils will make up to 80% of the cells you recover from your lavage, from your lung lavage, and that is a pointer to ARDS. When neutrophils make less than 5% of your lung lavage, is diagnostic or indicative of a cardiogenic pulmonary edema. The other one is that, don't forget when we started, the inflammatory mediators with proteinosis. So the protein, we look at the lung lavage protein over plasma protein. If we have more protein in the lung lavage with a ratio of 0.7, is indicative of ARDS. When the lung lavage protein over plasma ratio is less than 5, 0.5, is of cardiogenic pulmonary edema. Now, if I meet you in an exam and I feel led to ask you about ARDS, definitely I'm going to ask you to differentiate between cardiogenic and non-cardiogenic pulmonary edema. So you better remember this. Are we still together?
Yes, sir.
Yes, sir.
Okay. I didn't lose anybody. You are following me? Okay, so this table shows you, all right, how to approach a patient with B lines, on long ultrasound that is representative of pulmonary edema. So patients with acute pulmonary edema, you want to find out, is it non-cardiogenic, like I mentioned, or cardiogenic pulmonary edema? So you follow through this. Look at the history. Look at the chest X-ray. All right. Sometimes you want to do a transthoracic echocardiography. All right. And if your diagnosis is still uncertain, you want to do a pulmonary artery catheterization to measure your pulmonary capillary web pressure. What is missing here is the bronchoalveolar lavage I mentioned before. All of this will give you an indication of the origin of your pulmonary edema in your patient. So clinical presentation, how does the patient with ARDS present? Remember ARDS as your mnemonics. Number one, the event must be of an acute onset. All right, acute onset. Then you have respiratory failure developing. Hypoxemia within hours to days of an exciting event. And the era of COVID-19 actually brought the awareness of ARDS because most of the patients with COVID-19 who needed hospitalization and invasive mechanical ventilation developed ARDS. So when there's respiratory failure with hypoxemia, not responding to your conventional oxygen therapy, oxygen by face mask or nasal bronch or non-invasive ventilation, you're looking at ARDS. Then dyspnea with exertion and at rest, and then look at the signs and symptoms of an exciting event. Like our patient, we have the signs of sepsis. All right, temperature was high and all that, so you look at the signs and symptoms. This is how they present. All right, so your assessment, you'll see two different patterns, not specific physical findings, vis-a-vis tachypnea, increase in respiratory tachycardia, and you need high FiO2 to maintain oxygen saturation above 90%. All right, then you have fever or hypothermia, as the case may be. It depends on the level of sepsis that you have. Bilateral crepitations on lung exams. And you want to also look out for signs of congestive cardiac failure or intravascular overload and all that. This will point to cardiogenic pulmonary edema. All right, so risk factors, okay. Now the assessment, the severity. We usually use the PF ratio, that is PaO2 over FiO2, but the Kigali modifications, places where we do not have ABG, you can use your SpO2, FiO2. All right, this will give you an indication of severity. A lot of times, mild to moderate ARDS may do well with your non-invasive ventilation. But when a patient has severe ARDS, like the one we saw in this clinical scenario, this patient requires invasive mechanical ventilation. So you need to quantify the severity of ARDS when you have a patient with such condition. So laboratory diagnostics, all right, ARDS, everything about ARDS is ARDS. You want to do arterial blood gases. So when you have a PF ratio less than 200 millimeters of mercury, renal function, you want to look at, the blood urea nitrogen electrolytes, hematological work of liver function. All of these are laboratory studies that must be ordered for because they will give you an indication of the underlying inciting event. All right, chest X-ray in general is been done routinely. All right, and is usually sufficient for patients with ARDS. However, CT scan, chest CT is more sensitive, all right, because it will detect pulmonary interstitial emphysema. But listen, you must weigh the option, and that is why the Kigali modification becomes useful. Instead of moving the patient to the CT room, a long ultrasound can easily be performed by the bedside. All right, so this is just comparing a healthy lung and a lung with ARDS. You can see bilateral lung infiltrates on both sides of the lungs, all right, almost taken everywhere. And this is what we describe as the, what's it called now in radiology? Is it the water glass appearance or something like that? So there are bilateral infiltrates everywhere in the lung, chest radiography of a patient with what's it called, ARDS. In long ultrasound, I didn't get the picture here. What you could do, you'll see your B lines, more than 3 to 4 B lines on both sides of the lungs, and this is not responding to your diuretic challenge. All right, so the B lines will not clear with your diuretic challenge when you see B lines on long ultrasound. So this is characteristic of ARDS. All right, you want to look at the differential diagnosis like we mentioned before, okay? And approach to treatment. So you want to recognize and treat precipitated insults like we mentioned before, ARDS, adequate nutrition, conscious fluid. Let's go on, we'll have some time. All right, so management, many of us didn't talk about antibiotics in our clinical scenario at the beginning of the tutorial. Antibiotics is very important because we found out that more than 1/3 of the patient with ARDS came with pneumonia. So it's important. Antibiotics, broad-spectrum antibiotics, until you have your culture result. Respiratory support is the main treatment option. Diuretics here and there, and you want to put the patient in prone position. Let's go ahead. All right, so mechanical ventilation is the mainstay of treatment for ARDS. And like I was emphasizing earlier on, the goal is to maintain adequate arterial oxygenation. All right, because most of them have a pH ratio of less than 100. All right, so you want to do assist controlled ventilation, either volume or pressure control. All right, I prefer pressure control mode for those of you who have worked with me. All right, so you want to do tidal volume, but before you do that, you must calculate the ideal body weight of your patient, all right, which is given here. Male 50 plus 2.3 height in inches minus 60, while for female is 45.5 plus 2.3 height in inches minus 60. So initially you want to set the tidal volume at 8 mils per kg at the body weight, and you reduce by 1 mil per kg every 2 hours until you get to 6 mil per kg at the body weight. All right, inspiratory pressure should be less than 30 centimeters of water, and FiO2 PEEP. Okay, the next slides will show you the relationship between your FiO2 and your PEEP. But FiO2 should be kept high initially to ensure you have SpO2 greater than 90, and you want to introduce PEEP, all right, from anything above 5. Don't forget that PEEP of 5 is normal for everybody. So any requirement of PEEP greater than 5 is a diagnostic of ARDS. So you want to increase your PEEP to get your SpO2 greater than 90, and then you begin to titrate your FiO2 downwards. Don't forget that high FiO2 for a prolonged period of time will lead to oxygen toxicity and all that. So it's important for you to increase your PEEP in order for your FiO2 to come down as quickly as possible. All right, so the R, you want to recruit collapsed lungs. Those of you who have worked with me, you know Philippe. All right, I'm going to go to Philippe. So look at it. By the time your patient requires higher FiO2, your patient requires higher PEEP. You can imagine this patient has FiO2 of 100, that's 1. Okay, and you can imagine the PEEP requirement for such patients will be as high as 20 to 24 centimeters of water. So the higher the requirement for FiO2, the higher the PEEP that is required. This is what this slide is showing us. So long recruitment strategies or maneuvers in ARDS is known as Philippe. All right, P here is PEEP increment to prevent alveolar collapse. H talks about high frequency ventilation. All right, with respiratory greater than 100 cycles per minute. All right, the high frequency oscillatory ventilation helps to support gas oxygen by delivering very low tidal volume, all right, at a frequency of 3 to 15 cycles per second. The I, inverse ratio ventilation, all right, The normal IE ratio is 1 to 2, but in the face of refractory, severe refractory hypoxemia, you want to increase inspiratory time, all right, which helps to improve oxygenation. You can do 1 to 1, you can do 2 to 1. It depends on how far you go. And this is why we talked about permissive hypercapnia in managing ARDS, because as you increase your inspiratory time, you're going to have carbon dioxide accumulation. And that is acceptable if it's in less than 24, 48 hours in order to improve your oxygenation. All right, L is low volume ventilation, which also limits alveolar overdistension. Inhaled nitric oxide, all right, a selective pulmonary vasodilator, has been used to improve oxygenation in severe ARDS. Proning your patient, especially when your PF ratio is less than 140. So this patient in a clinical scenario, one of the things that would be ideal for him is for this patient to be placed in prone position. So indications for proning in ARDS is very low, PF ratio less than 140, and when your PaO2 is less than 60 at FiO2 of greater than 60. All right, if you have facilities to prone the patient should be prone to improve oxygenation. ECMO, all right, is like a gap stop, management for this patient to buy time. And the venovenous ECMO is primarily used in ARDS to provide gaseous exchange. All right, so one of the questions I like to ask a lot is I'll ask you to give me the protocol of how to achieve low volume ventilation in ARDS. Please cram this, okay? You must know this. What is the protocol for low volume ventilation in ARDS? So the first thing is you want to calculate the patient's ideal body weight, all right? And you set your tidal volume at 8 ml per kg ideal body weight, and you gradually come down. Second stage is you want to measure your plateau pressure, all right, at the tidal volume. Once you get a tidal volume of 6 ml per kg ideal body weight, you want to measure your plateau pressure. If at this point, your tidal volume of 6 ml per kg, your plateau pressure is more than 30 centimeters of water, you need to decrease your tidal volume in 1 ml per kg until you're able to achieve a plateau pressure of less than 30. The third stage is you want to monitor ABG for respiratory acidosis. This patient had 7.25, so it was in respiratory acidosis. So if the pH is between 7.15 to 7.3, you will need to increase your respiratory rate, like Dr. Wango mentioned initially, until you're able to achieve a pH greater than 7.30 or respiratory rate greater than 35 cycles per minute. Now, if your pH remains at 7.15, you want to increase your respiratory rate to 35 per minute. And if it's still low, what you do is you increase your tidal volume in the increment of 1 ml per kg until you're able to achieve a pH greater than 7.15 rather. The goals of your management is you want to, this meeting is being transcribed, okay? All right, so the goal is you want to have a tidal volume of 6 ml per kg, your plateau pressure less than 30 centimeters of water, and your pH between 7.3 to 7.45. So this is the protocol for low volume ventilation in ARDS. So in summary, I like mnemonics. In summary, you have 5 P's, all right, for ventilatory support. Mind you, this is ventilatory support, which I mentioned to you is the mainstay treatment for ARDS. So the first P is protective ventilation, all right, because these patients are prone to volume trauma, arterial trauma, all right. Permissive hypercapnia, all right. As long as the pH is greater than 7.2, permissive hypercapnia is allowed, all right, because you don't want to give high tidal volume, all right. In as much as you want to increase your IE ratio, all right, you expect some accumulation of carbon dioxide. So permissive hypercapnia, positive end expiratory pressure, all right, prone positioning and paralysis. Somebody mentioned muscle relaxant. Sometimes these patients, you are not able to achieve adequate IE ratio and improve oxygenation, all right, you may need to give this patient some muscle relaxant, some muscle paralysis, all right. And usually when I'm forced to do that, I don't do it more than 24, 48 hours, because prolonged use of your muscle relaxant will leave your patient to be ventilator dependent, and you can have critical illness polyneuropathy in this group of patients. So the 5 P's of the ventilatory support is what is here: protective ventilation, permissive hypercapnia, application of PEEP, pronate, and muscle paralysis. All right, so this is just a table detailing the ventilatory support strategies for patients with ARDS. All right, don't forget supportive management is crucial. All right, hemodynamic support, you want to maintain your MAP above 60. You can do this with judicious fluid administration, and sometimes you may want to use, you may be used to your inotrope or vasopressor, and you want to achieve a cardiac output at 5 to 6 liters per minute. All right, that is corrected for total surface area of the patient. Hemoglobin, if the hemoglobin is less than 10, you may want to transfuse to keep your hemoglobin above 10. All right. And steroids, like I mentioned before, high dose steroids in the range of 2 to 3 milligram per kg per day, 7 to 14 days after onset of illness. This is crucial. All right. So the benefit of steroids in late ARDS is the ability of steroids to promote collagen breakdown and inhibit lung fibrosis. You know, remember I told you that the latter stage of pathophysiology, fibrotic stage. So you want to start steroids about 7 to 14 days after diagnosis of ARDS. Heparin for DVT prophylaxis, all right, GI prophylaxis. Follow the normal fast curve that I've taught you before, and this will make up the supportive management for this patient. All right, I mentioned non-invasive ventilation. This is usually applicable for patients with mild to some moderate ARDS, and you can use different modalities. All right, I think I'm done. So let me leave room for questions, for discussion. All right, let me stop the recording.